I will be presenting on hypothyroidism. Patient TE, a 67-year-old native Hawaiian, presents to Bay Clinic Hilo on February 27 at 9:30 a.m. for medication management. TE was previously diagnosed with hypothyroidism in 2002. Patient reports no symptoms of palpitation, tachycardia, headache, difficulty breathing, or increased heart rate. He also denies heat intolerance and nervousness. In addition, TE denies feeling tired, sleepy, lethargic, or depressed. For past medical history, patient has been diagnosed with the following conditions: GERD, hyperlipidemia, and vitiligo. For family history, TE's mother is currently alive, but as far as family history of cancer, CVD, or premature death is concerned, information is unavailable. TE is a current smoker who smokes 4 sticks per day for about 40 years. He currently is single with no children, and he lives with his disabled mother, of whom he provides primary care. Patient denies illicit drug use and alcohol use. He enjoys drinking coffee and prefers his coffee black. As far as diet is concerned, TE mainly enjoys stir-fried food, soup, and stew. Information regarding his work setting, sexual activity, and exercise routine was unavailable. TE is currently up to date with his immunization history, with his last flu shot received on September 2011. For negative findings, as mentioned above, patient denies symptoms of palpitation, tachycardia, headache, difficulty in breathing, or increased heart rate. In addition, patient denies upset stomach pain, and he also denies congestion. For positive findings, patient is more energetic as opposed to being tired and sleepy. Patient also reports experiencing runny nose and sneezing when fog is present in Hilo. In addition, patient has had a consistent weight but does report weight gain from time to time. Overall, patient appears happy, healthy, and well-nourished. For medication adherence, TE has been consistently taking his medication as prescribed. For vitals, TE presents to the clinic with a BP of 126/74 and a heart rate of 72. His respiratory rate is 18 and his temperature is normal, 98 degrees Fahrenheit. He weighs 193.8 pounds and he stands at 5'11". For lab and other findings, TE has an IBW of 75.3 kilograms, a BMI of 27, considered overweight, a basal energy expenditure of 1,726 kcals per day, and a creatinine clearance of 64.7 milliliters per minute. His AST and ALT levels are within normal range, and his BNP panel is within normal range. His lipid panel, however, is slightly elevated with increased total cholesterol and LDL levels. As far as his TSH is concerned, he is consistent and within normal limits. On January, he had a TSH level of 3.21 milliunits per milliliter, and on September last year, he had 3.49 milliunits per milliliter. TE is not currently allergic to anything, and there are no known drug allergies. For his current medication, he is taking for hypothyroidism levothyroxine 125 micrograms, 1 tablet daily. For GERD, he's taking cimetidine, and for OTC prescription or medications, he is taking aspirin low dose. As far as assessment is concerned, causes of hypothyroidism per Dipero 8 edition. Primary causes include Hashimoto's disease, iatrogenic hypothyroidism, iodine deficiency, enzyme defects, thyroid hypoplasia, and goitrogens. Secondary causes of hypothyroidism include pituitary disease and hypothalamic disease. TE's Framingham 10-year CHD risk score is at 16%, and he has a vascular age of 46-year-old. For current therapy, TE requires continued treatment for his hypothyroidism since thyroid hormone affects the function of virtually every organ in the body. In addition, thyroid hormone is essential to maintain metabolic activity. According to treatment guidelines by ATA and AACE, the drug of choice for treatment of hypothyroidism is levothyroxine. TE is currently taking levothyroxine 125 micrograms orally every day. Dose is appropriate for the patient since he is within normal limits of TSH levels. The route and frequency is also appropriate for the patient, allowing feasibility of patient compliance. Also, patient reports no symptoms of adverse effects. Overall, levothyroxine is appropriate for the patient as recommended by ATA and AACE guidelines. Therapeutic alternatives for treatment of hypothyroidism include desiccated thyroid hormones, combinations of thyroid hormones, or triiodothyronine. However, per AACE guidelines, all three alternatives are not recommended due to a lack of sufficient evidence. Chronic therapy with triiodothyronine alone is not recommended per ATA guidelines because its use has been associated with a greater degree of iatrogenic hyperthyroidism. Combination therapy, both biological and synthetic, per ATA guidelines is also not recommended since combination therapy produces fluctuating and elevated T3 concentration. Furthermore, two meta-analyses conducted in 2005 and 2006 further suggest that combination therapy versus levothyroxine monotherapy has no benefits. For medication interaction, patient has no medication interaction. Our plan for TE, our recommendations for drug therapy. TE should continue taking his levothyroxine dose 125 micrograms daily since his TSH levels are within normal range. In addition, per AACE guidelines, I recommend not to change the current brand of levothyroxine throughout the course of treatment since levothyroxine has a narrow therapeutic range and switching brands may result in substantial changes of TSH levels. For medication reconciliation, there is none to discontinue. Recommended drugs to consider avoiding dependent on patient-specific parameters: iodine 131, ferrous sulfate, sucralfate, aluminum hydroxide antacids, phenytoin, carbamazepine, cholestyramine, cholestyramine, digoxin, beta-adrenergic antagonists, because these may decrease levels of levothyroxine. Drugs to consider avoiding also are drugs used to treat hyperthyroidism, which include propylthiouracil and methimazole. TE should also consider avoiding drug-induced causes of hyperthyroidism, which include amiodarone, rifampin, interleukin, interferon alpha, and lithium. Our recommended test for TE as of the moment is none. However, when patient returns to the clinic, I would like to follow up on his work setting, sexual activity and exercise routine, as well as his family history. Our goal for TE is to maintain his TSH concentration within normal limits and to maintain a healthy overall well-being and avoid end organ effects. For monitoring parameters, we would continue to monitor TE's TSH levels every 6 months to a year per AACE and ATA guidelines. If any changes are made to TE's current dose, then we should monitor for approximately 6 weeks until TSH concentrations are within normal limits. We should also monitor for signs and symptoms of both hyperthyroidism and hypothyroidism. Signs we should watch for hyperthyroidism include nervousness, anxiety, palpitation, and heat intolerance. Signs we should watch for hypothyroidism include lethargy, weight gain, constipation, depression, fatigue, and loss of energy. Since TE's last TSH levels were drawn in January, he should return to the clinic on July to ensure that his TSH levels are still within normal limits. Drug-related side effects to monitor for include palpitations, tachycardia, cardiac arrhythmias, headaches, nervousness, insomnia, diarrhea, vomiting, and decreased bone density. For patient counseling, hi TE, you are doing a good job with taking your medications consistently. Please tell me what medications you are taking for your thyroid. Okay, I advise you that you continue what you are doing and take your levothyroxine 125 micrograms every day by mouth, preferably at the same time every day, which should be in the morning around 30 minutes right before breakfast and must be taken on an empty stomach. What do you do when you miss a dose? If you miss a dose, take your missed dose as soon as possible. But if it's close to time for your next dose, you can go ahead and skip that missed dose and take your next dose that you are scheduled for. How do you store this medication? TE, your medication should be kept away from the reach of children and away from sunlight or moisture and be stored at room temperature. This medication is not intended to cure you, and you may have to be on this medication for your entire life. Please do not discontinue your medication even if you're feeling better. If you experience any signs of headache, nervousness, diarrhea, excessive sweating, heat intolerance, chest pain, increased heart rate, palpitation, please contact your doctor right away. Also, you want to avoid taking your medications with antacids, multivitamins, or iron preparations because this may decrease your drug concentration. But if you have to take antacids or iron preparations, you can take them, but take your levothyroxine first, then 4 hours later, take your antacid or iron preparation. For non-pharmacological interventions, I would tell TE that your weight is considered on the heavier end, and I recommend that you incorporate fruit and vegetables into your diet. Also, I recommend that as much as possible, try to incorporate exercise into your daily routine, and try with walking at least once or twice a week for about 30 minutes. TE, I know that you smoke 4 sticks per day, which is less than what you used to smoke in the past. I recommend that you quit smoking because it puts you at an increased risk for cardiovascular events in the future. And for information resources, I would give TE a 1-800-QUIT-NOW number and a handout containing information on his Synthroid medication. Thank you.